Thank you so much for the introduction. You've heard I'm a nutrition scientist. And when I started at this clinic and I realized, oh, we are working together with surgeons. Can you imagine what it meant? I had learned nothing at the university about bariatric surgery. I was trained, yes, you do lifestyle change and then you lose weight. But I have to admit, I have conversed, and I will guide you through why, but it's still not without doubts and criticisms. And I want to share this also with you. Why did I change my mind? You have to imagine a patient weighing 140 kilo, 1.7 meter high with a BMI of 48. If they lose weight, 20 kilo, 40 kilo, without any bariatric intervention, they have done a great job. But they are still obese or overweight. They don't get this, oh, wow, you have lost weight, it's great, because you don't see it. And this is, I think, a very important factor for patients to go on. And as you have heard before, maintenance of weight loss, that's the real big issue. To lose weight, it's more or less easy, especially for men. It seems being much easier. But this is something I realized with my first weight loss group, with morbid obese patients. I thought, oops. So bariatric surgery might help these people who engage very much. And I don't want to go into the details of the different techniques. What it is about is you restrict food intake and you add a malabsorption. BPD, pancreatic diversion, is the most effective, but this needs really a tremendous compliance of the patients. At the moment, as you see here, I have taken together Austria and worldwide data. What are the most often performed procedure is the gastric bypass. A new technique is a mini gastric bypass. Gastric banding was popular 20 years before, but this has changed tremendously. Sleeve gastrectomy is worldwide much more often done than in Austria. Do you have an idea what could be the background? Expertise, yes, and preference of the surgeon. So we are lucky. We have very skilled surgeons who can do the, let's say, more complicated procedures, but worldwide you see more sleeve gastrectomies, also because it's maybe less demanding for patients to adhere to changes. And the most well-known study is the SOS study, Swedish obesity surgery study, and they have long-term outcome, which is a great thing. And you see, gastric bypass is the most effective procedure, banding less effective. But what you also see, and I come back to this, patients regain body weight. What are the indications? Guidelines say patients should be morbid obese with a BMI 40 plus, or if they have comorbidities and they could not sufficiently and sustainably lose body weight with a conservative treatment. We are a bit careful with older patients. I have to admit, I'm not only careful, I would say you really have to think about it. if you go for bariatric surgery in aged patients, because with age you lose muscle mass. That's physiologic, and then you add a really severe intervention. At the moment, there are a lot of discussion going on or went on. Now we have new guidelines. What you see, patients with diabetes who get this bariatric surgery, they make it much better than controls without this kind of intervention in terms of remission. And it depends very much how long a patient was diabetic. So the new consensus is that, you see, we are now moving to BMI 30 to 35 for patients with diabetes. There is still, in our country, there is a lot of discussion, and you have to imagine, if you want to give all these patients with a BMI over 30 who have diabetes surgery, who can afford this? Our healthcare system is not prepared to give this operation. So it's efficient, effective, but as Maria yesterday always had this, but, yes, we nutrition people have quite often buts. There is a lot you should think of when you are dealing with this kind of patients. Nutrient deficiencies preoperatively, then weight loss. Should they lose weight before operation? And postoperatively, nutrition care, they need supplementation, but there is a lot to say about it. So let's start with preoperative deficiencies. This is, many doctors don't think that somebody who is morbid obese can be micronutrient deficient, because you eat, you have everything you need. But that's not true. Various studies show that, especially here, look, vitamin D deficiency, but also vitamin C, zinc. So there is a lot to do before they get the operation. We should, in a clinical setting, correct the deficiencies as much as we can. Then we recommend preoperative weight loss because it facilitates the surgery. Liver volume is shrinking, and the subjective perception of the surgeon is the operation is easier. But, again the but, if you don't care, you can aggravate the micronutrient deficiencies if you tell the patient, go home and lose weight. Let's say with a lemon juice diet, or with the ananas diet, or with whatever. I mean, this is what happens in practice. They don't receive quite often proper guidance. So, yeah, go home and do it as you tried before. But this is not, in my perception, it's not a solution. It needs a proper nutrition counseling, guidance. It needs a focus on micronutrient supplements, because if you reduce the volume, just the volume without thinking of quality, they really will aggravate their deficiencies. And in my country, at least, there is a lot of discussion who is paying for this, because nutrition counseling is only covered in a hospital. If you do it on a private basis, you don't get any reimbursement. So we leave patients alone if there is not a kind of center of excellence who can provide this. It makes sense, and it seems quite easy with a very low calorie diet, as shown by Coles, that you reduce the liver volume, they lose weight. You give them, besides this, multivitamins and 12 elements. But, again, it's a liquid diet. And we want that patients learn before they get the operation to chew properly, to have 5 small meals a day. Because everything you have learned without stress, then you can practice when it is stressful. And post-operative phase, the first 6 months, I would say, is really stressful for patients. So they get the operation, as I showed, most of them, the gastric bypass. They lose weight. The problem is solved, isn't it? That's great. No, it's not. They regain body weight. We say after 2 years, latest, the honeymoon phase is over. Because the first 2 years, they lose body weight more or less without changing lifestyle. They have the operation and they lose. But after 2 years latest, the real life is back and they gain weight. And as shown by this study, impact has the time since surgery, means the longer the time between surgery and actual date is, the more they have gained. But there are other influencing factors, like the emotional eating, food urge control. So they need guidance, they might need psychotherapy, portion size control. It's because we recommend only small portions, 5 portions a day. But, then it comes, but I don't have time. I can only eat 2 meals a day. If you eat 2 meals a day, you start overeating and you accept that you vomit. So the system is again running out of order. And change of physical activity. I'm not going to talk about it, but this is another important issue besides nutrition, that they start moving, and they can, if you have to imagine, you lose 40 kilos, then you can walk again. You can manage to go upstairs. But if they don't understand, they don't start with this, they don't change behavior, it's clear they regain body weight. The other issue, and I think it's really important, is that as the portions are so small and as many of them eat as they did before, only smaller portions, some of them have never heard that they need a multivitamin. We see quite a lot of deficiencies. You can see protein is mostly the first 6 months seen, but also vitamin B12, vitamin D. And I go through this briefly. Protein intake, again, needs a change, and the change is that they can't eat, for example, different types of meat they were used to before. So what do you choose then? You need guidance, and you need a minimal intake of 60 gram protein per day. This is manageable if the patients adhere to a protein supplement, at least for the first 6 months. But what this study from Andreu shows is it's not easy to make it, even with supplements, to reach the 60 gram per day. But without, it's possible for every second patient. So a supplement is a good idea. Another idea, because I'm also active in the field of disease age-related malnutrition, and with the aged population, it's always about preserving lean body mass when you age. And there is a lot of research going on. You need exercise, yes, bariatric patients need exercise. Dairy protein consumption is an easy way to get protein, same for bariatric. A higher protein intake, same. Slows the weight loss, this is something we don't want, but they should distribute the protein intake over the day and not one bigger portion, smaller portions over the day. And there is, at the moment, a lot of research going on about the amino acid leucine, whether leucine helps to preserve muscle mass. I think this is an interesting concept also for patients after bariatric surgery. Carbohydrates. What we have done, we have taken consecutively 50 patients and done a mixed meal tolerance test and a continuous glucose monitoring. And what we saw that more than 70% of the patients have hypoglycemia. Many of them don't realize that they have a hypoglycemic event. Trigger foods are not unexpected, sugar-rich, star-rich, but also if they have long fasting periods between meals. So again, we are back 5 meals, small meals, and change behavior. So give them counseling, give them guidance. Give them guidance that they need a multivitamin trace element supplement. The American guidelines say 200% of the recommended daily allowances. But again, you can say, yeah, take one. But you should know what the patients take because what is on the market is so diverse. If they go to a pharmacy, if they go to one of the supermarkets and buy something, or as I have collected here, Fit for Me is a product which was developed in a clinical trial with bariatric patients. So you see they have higher concentration of vitamin B12, for example. They have more zinc, but they don't have calcium. The others have this in different concentrations. Why do they do this? Why is this prepared as such? Yes, the calcium carbonate is less good available as calcium citrate or fumarate. So they have a special preparation. And the other thing is that if you give calcium and iron together, the iron absorption is much lower. But this means if you say, okay, you go for this Fit for Me, I don't get any money from them, but it's that you know what is on the market, then you have to tell the patient, okay, you need calcium as well. Huge tablets. It's not easy to swallow. And if there are huge tablets, in principle, patients have difficulties to swallow. Vitamin D, bone metabolism, you see often. And it's really not easy to get patients to a normal level of vitamin D. In our group, we have done this intervention in a randomized placebo-controlled trial. The intervention was a load with vitamin D. Day 1, 14, and 13, 100,000 units. In total, a load of 300,000 units. And you see the recommendation for healthy adults is 800 units per day. And then they received a maintenance dose as a placebo dose group. And what we see is, yes, with the load, we can manage that patients come to a more or less normal state. Next time, we thought we would try to give it before the operation, and how long they can hold the vitamin D level. But what I think is still interesting with this study is that at the beginning, patients don't absorb these high doses after the operation. So especially at the first weeks, they hardly absorb anything. Vitamin B12 is critical, especially in BPD and bypass patients, because you change the anatomy of the stomach, and they don't have intrinsic factor, so they can't absorb vitamin B12. Plus, they have medications, metformin or proton pump inhibitors, and we have only a very small percentage of passive absorption. So these patients need B12, but in the community, it's still under discussion. How do we do this? And if you look in the different countries, we do it differently. This group gave oral supplementation, and they had only about 10%, but the longer it's away from the operation, the higher the incidence, and if you follow this further years, it will go up. We did, in a very small pilot trial, an intervention with a spray, as a passive diffusion, which works, but still the intramuscular application of B12 is more efficient. And quite a lot of the patients were unsatisfied with this spray, because this is something then you have to do at least twice a day, and you have to remember that you have to do this. So we think, yes, patients can do with the spray, but it very much depends on their compliance, whether they manage or not. And those who are from the nutrition field, they know that a high dose of a vitamin does not consequently result in high blood levels, as you see here with this example with vitamin C. So this is again something, but it's not studied in these bariatric patients, because as we know, nutrition studies, who is financing nutrition studies? There is no big money behind it. And it's not only the dosage and the different types, it's also that you have to think of interactions between the different nutrients. For example, iron deficiency might decrease the mobilization of retinol from the liver, and then you think you have a patient with retinol deficiency. So it's really not one-dimensional, it's a multidimensional issue that you have to have in mind different aspects of nutrition and supplementation. Another example, zinc and iron, higher doses, and many patients, because they lose their hair, then they go to a dermatologist, they learn you need zinc, that your hair grows again. So they take high doses of zinc. If you don't ask them, they will not tell you. And then you're wondering what's going on with the iron. So high doses of zinc lower the iron absorption. If you give a high dose, this is something you could think, a high dose of zinc with a high dose of iron, the iron bioavailability is halved. If you leave some time between giving zinc and iron, you have no inhibition. This is what we do when we say iron and calcium. So we don't give it together at the same time. A big issue I said before is adherence in our study. And you have to imagine, taking part in a clinical trial, you get a lot of attention, a lot of doing around, and still adherence to maintenance doses was, I would say, is not very good. I would love to see, or I had expected a much better adherence. But it's not, we are not the only group who experience low adherence rates. Others do as well. 22% non-compliant patients, and the less compliant, the more deficits you see. A good indicator is how often patients come back to the controls in the clinic. And a very nice study done in Italy, I like it very much. They systematically prescribed supplements, and then they had an electronic monitor at the box. So they asked, how did you follow our recommendation? And you see, most of them followed very nicely. But when they checked the box, you see, wow, this is amazing. Only every third, and then 6 months later, it's even less. So this is something I think we need much more research. How can we increase adherence of patients? And if you ask patients why do they forget, it's not only forgetting, it's difficulty of swallowing if the pill is big, but it's complex. Imagine you have vitamin D, then the multivitamin, then you might need iron, and the iron should go 2 hours before the calcium. It's really complex. It's not an easy task. Some of them have depression. It costs, and many of the patients are from with a lower socioeconomic status. And this is something they don't think about it when they start the whole process. Because, oh, yes, I'm nearly done. And what you see, if you don't take it, it doesn't hurt. You don't feel anything. You experience, let's say, 6 months, a year or 2, but then you can't make the connection. So what we need, I believe, we need much more research in the adherence field, but we also need more research in what is the best dosage, how, when, interactions. A lot, you can think about it, pregnancy, as now more and more younger women receive the operation, they become pregnant. We don't know what is the best doses. We give them what is recommended for healthy adults. But alcohol, we know that those who drink alcohol have a higher chance to become alcohol dependent. So take home, yes, it's a very effective procedure, but patients need not only monitoring, they need a lifelong care, and we have to accept that it's a partnership. If we and the patients don't accept it's a partnership, we will not succeed, and we will see a lot of complications post-operatively starting 2 years after. And the other thing, I really think we have to move our focus away from weight loss to nutrition, to physical activity, to body composition. And we should also try to move away from this star business as the football teams have. We have also a star, and every team has a star who is the surgeon. But there are normally many, many people around who support him that it's going well afterwards. Thanks.
Thank you very much. This was excellent. And thank you for stressing the importance of nutrition before and after. Actually, a few comments. In the States, all the insurance companies, they pay for 6 months before, and you have to see the nutritionist, and the nutritionist has to give you a paper at the end of the 6 months saying that you are allowed to take the bariatric surgery. And I find it very good, and I think all the countries should go for such a procedure. This is point one. You want to say something about it?
Yeah,
because I have two more.
We had the same idea in our country, and I know in Germany it's the same. The insurance does not pay, but we thought we do it as a trial, and then some of the surgeons in the city said, yeah, but you know, then we lose patients because it takes 6 months to prepare them.
Yes, but it must be obligatory, in my opinion, and I'm sure you agree.
So too, yes.
The second point was about vitamins and minerals, etc. Again, in the States, they don't give it in pills. They give it either in a liquid or in a powder form, and I think this is very helpful for the patient, because if you ask him to take 5 pills, you lose the patient. I mean, he's not going to do it, and it's very difficult for him. You agree on that? So,
yeah, I agree, but in at least in my country, it's only Superdyn available as a liquid.
Yeah, so we have to work on that and have new powder formulas for these patients, because it helps a lot. And also it helps because they dilute it in water.
Yeah.
Which is, I believe, the third point was that we have to be very, very careful with water, and because most of them, they are dehydrated. They have to take all these liquids in the beginning, and they don't want to do it, and it's very difficult for them. So this is another problem I wanted to add to what you said. And finally, my experience is that they come back with a lot of deficiencies. And maybe I will go back to your comment. I'm not sure at the end of the day if it's so helpful for them. Because most of them, they regain weight. Most of them, at least in my country. After 2 years, as you said it very well. And also they have so many deficiencies that if we don't find some way to solve them, their health is not that good.
Yeah, that's true. You need a multidisciplinary team working there, and patients there should be a way that they come regularly. We say the first 2 years, every 6 months, and then every year.
Any other questions?
Well, thank you very much. Very clear. Very clever to combine topic of surgery with nutrition. So I call that a gender setting, but you do it in a very good way. Talking about the weight regain issue, we are now involved in discussions on whether rapid weight gain at the start leads to a larger weight loss at the end. And also the recommendations say, well, weight loss of 5% at least, or 10, is sufficient enough to reach the metabolic health outcomes or the other health outcomes. But watching your presentations both, I realized we are taking the weight regain for granted. And it seems that all interventions have weight regain. Don't we really have one single study showing no regain at all?
I don't know.
It starts surprising me more and more.
Yeah.
And if not, why do you think there is no single study without any weight regain? I have a solution, but I wonder what your thoughts are.
My thoughts are, first, it's the metabolic state. who triggers weight regain in a way. I have no data about it, but I think that this would make sense. And the other thing is what we see, that patients don't realize that they have to change lifestyle. So, you know, at the beginning, the first 4 weeks is horrible. The first 6 months, you are losing 20 kilos? Wow, without doing anything. And this is maybe the disadvantage of the surgery, that it goes without much effort. So if you have clever people and if you have a good team, I think you can manage that they understand.
Yeah, and this is my argument against the large weight loss in the beginning, because then the motivation is, as you seem to suggest, on the weight loss and not on the actions being taken by the individual. But both of your presentations are very individually oriented. And we know that the real drivers of the obesity epidemic is the environment. So I would think that the weight regain is the result of the environment. So we should do these interventions in healthy environments. Do you agree?
I'm completely with you. Completely. Because, I mean, it's the thing. They get pregnant, they eat as they did before. And then the kids learn what their parents have done wrongly all over their life. And the whole business starts again. So I'm completely with you, working on a healthy environment. That's the first step.
And Tommy, just a brief comment. Why weight regain is always occurring. It's a new set point, right? It's a concept called adaptive thermogenesis. So with the same body composition, theoretically, you have a lower energy expenditure. We still don't know how to explain it. So even if you're lean and you go on an expedition to the Rocky Mountains and you lose 7 kilograms, and when you're back and 2 weeks later you have again the same body weight as a lean individual, your energy expenditure is lower. So if you then maintain your lifestyle, you will slowly gain weight. And that's also what we see when you have the yo-yoing effect. So the first attempt is usually the most effective. If you regain weight again, try again, it's more and more difficult to get the weight off. So that's really intrinsic physiology also what's occurring.
We are not able to.
No, so you should change. You should reduce indeed your energy expenditure just a little bit, and increase your energy expenditure a little bit, and reduce your energy intake also a little bit. And it's demanding, and therefore it's not successful in a lot.
But for these particular patients, they also change their food habits, because in the beginning they are scared and they're doing whatever their doctor says, and after a certain period of time, they just relax, and then they find ways to cheat, their stomach. They melt the ice cream, and they do all sorts of different things you cannot imagine. Because if you find out how they increase their energy intake, is incredible. I mean, they find ways to get more energy. So but it's both. It's both physiological and behavioral changes.
And I mean, in many countries, you need this that you go to a psychologist and they look whether you fit for the surgery or not. But in Austria, at least, you see the psychologist once. Do you build trust with a psychologist and then maybe come up with sexual abuse? I doubt it. So if you have a good team, then at a certain point, and there is enough trust, this will come up, because this is sometimes behind when they start drinking chocolate, that they can't lose mentally the body weight. I strongly believe that you need a very skilled multidisciplinary team to deal with these patients, to make it a success for a patient. Also, the long-term outcome for these patients.